Panoramic, Xray, PCRI, or post-calibration form. Here at the top we have the facility name, Hospital XYZ, along with the equipment control number, or ECN, also known as the asset tag or index number. Moving along, we have the system identification number, which is the manufacturer, plan mecha, the maximum tube potential, which we can find right off the tube, we also have the make and model, the control serial number, and the tube serial number. Moving along, here are some visual and operational inspections or checks that we will perform. First is the beam check. Here we will go into the software and actually take a shot and measure the contrast and densities of the beam. Next is the warning indicators, the dead man switch or exposure termination. Here we'll press the button, and halfway through the scan we'll release the button, and it should alarm premature exposure. We're going to do some mechanical checks. We're going to check the tube, the lift, the locks, operations, check the tube cover, we're going to check for any oil leaks, check the switches, also the LEDs, make sure everything's operational, and we're going to ensure that the tube rotates smoothly. And this is a pass or fail. Moving on to the qualitative testing. Here we have line regulation, which measures the applied power quality or transient spikes, noise, harmonic distortions, such as the shape of the AC waveforms, flicker, under voltages, also known as brownouts, also over voltages of incoming voltages with no load and under a load while taking an X-ray. The formula is no load divided by load multiplied by 100. Here's our no load versus our load, and that's our drop, which should be less than 10%. Why do we measure line regulation? Without good quality power applied to any device, especially medical devices, it will not function properly, and technicians will start to experience premature failures and premature malfunctions, voiding the warranty. Timing. Timing is measured non-invasively with our QA meter or Piranha, and it's set at preset technique such as 70 kV at 10 mA, so that it can be fired at preset pulses for short or long durations. You can configure those pulse settings in accordance with your device's OEM, make, model, specifications, or your individual preferences. Here we have 4 shots that we're taking set at 5 milliseconds. Why is timing so important? Timing quality directly impacts the total quantity of radiation exposure to the patient. Accurate timing exposures are critical for image quality and conclusive evidence of reducing high patient dosage, which are linked to increased risks of cancer. This is measured in milliradian. KVP verification. This can be performed either non-invasively or invasively. 60, 70, and 84 kV set at a constant MA, which we are measuring non-invasively using our digital multimeter. And then we're using the conversion factors to actually calculate the measured KVPs. Why is KV verification so important? KVP quality directly impacts the quality of the image and the density levels, which is the image thickness, as well as the contrast or the brightness on the film or the monitor. Moving along to MA verification. MA verification can be performed also either non-invasively or invasively. If tested invasively, then the corresponding voltages are equal to MA. I recommend that you check with the OEM what those corresponding voltages are. Here on this test, we have a kVp that is constant with a varying MA, which we have measured with our digital multimeter. Why is MA quality so important? MA quality directly impacts the quality of the image and patient dosage for the purposes of radiation protection and assessment or risk of radiation overexposure to the patient. Ceph time verification. Ceph time verification, this is similar to testing the regular panoside timing circuit, only the difference now is we are testing the Ceph side. It can be measured non-invasively with the QA meter, which is set at preset timing intervals that can be fired at preset pulses for short or long durations. Again, you can configure your pulses in accordance with your device's OEM make and model specifications or your individual preferences. Now in this case, ours is not applicable because we do not have the Ceph function. Reproducibility. This is measured non-invasively with a QA meter, Panoramic, and Xray device control techniques set at preset timing. A series of X-ray shots are then averaged together and measured. As actually shown here, we are taking 4 shots, but actually we're taking a series of 8 shots. We will take the first shot, then we will take another shot, which is an in-between shot, and then take the shot and ensure that the reproducibility or the accuracy. Why is reproducibility so important? It ensures that for the X-ray shot, the X-ray device will deliver the same series of repeated exposures each and every time. That's why we take the 8 shots, the same way every single time. The reproducibility test is valid for devices operated on adequate incoming power quality or line regulation. An MR exposure value that differs significantly from any other values other than what is rated at is suspicious and may have been produced during a substantial voltage drop caused by transient voltages. And here is our actual average in milliranking. Moving along to beam quality or half-value layer. Beam quality or half-value layer is measured non-invasively with the QA pyranometer and X-ray device control technique set to a preset timing shot of 1 second. What is half-value layer? Half-value layer of an X-ray beam is the thickness of the absorbing material or the aluminum sheets necessary to reduce the X-ray intensity to 1/2 its original value. As shown here is our half-value layer, and this is our formula. So we're measuring half-value layer in milliranking with the maximum of 2.5 millimeters of aluminum. First we start off with no aluminum, then 1 millimeters of aluminum, and finally 2.5 millimeters of aluminum. Why is half-value layer so important? Half-value layer provides important information about the radiation energy characteristics of the X-ray beam. Basically, if half-value layer for the X-ray beam is low or thin, then the X-ray beam contains more low energy and less penetration radiation. If the half-value layer is high or thick, the X-ray beam contains more high energy or high penetration energy. This is important because X-rays used for correct patient diagnosis must have enough radiation to penetrate the desired body part and effectively expose the image or the patient on the film. This is because lower energy radiation absorbed or scattered by the body and may not reach the film. On the other hand, if there is too much filtration in the beam, the X-ray beam energy becomes too high and there is a loss of contrast on the X-ray image. This is why it is important to have the physicist evaluate all X-ray equipment on a regular basis, typically once a year, and measure the half-value layer as part of that testing. Second application of half-value layer in an imaging department has to do with room shielding. Rooms that contain fixed X-ray equipment are typically shielded with lead-lined walls to reduce the radiation exposure to workers and the public from the use of X-rays within that department. When designing the shielding for a room, the physicist will perform calculations based on the half-value layer of the X-ray beam. In general, the design will call for enough half-value layers of shielding to reduce radiation exposure outside the room to acceptable limits. For example, if the exposure rate at the wall side of the room is 16 arbitrary units and we want the exposure rate just outside the wall to be 2, we would use 3 half-value layers of shielding. The first half layer reduces the exposure rate to 8, the second half value reduces it to 4, and the third reduces it to 2. In practice, there are some other factors that must be taken into account, but this provides the basic idea. Geometric exposure. Here we are using a geometric spatial phantom to measure the distances between each geometric circumference. We have a preset technique of 66 kV at 9 MA at 16 seconds with a tolerance of less than 3.2 millimeters of difference. Once we have the ball phantom set up, we take a shot and we measure from the far left to the 10th ball, and then we move from the right and measure the 10th ball and take the difference of the two, and it should be less than 3.2 millimeters. Finally, we perform any action required as well as have the technician sign the form.